I'm Debbie Harvey, GP Lead for Cheshire Merseyside Cancer Alliance. In this short video, I will explain how the use of FIT and referral practice for suspected lower GI cancers is changing in our area. Most of you watching this will already know that FIT is a simple stool test that detects human haemoglobin and is used in both screened and symptomatic patients. It's important to recognise the critical differences between screening and symptomatic FIT. For screening FIT, people are invited between the ages of 60 and 74 with ongoing staggered age extension from 50. This is offered every 2 years and works on a threshold of 120 for investigations. For symptomatic patients, people can be invited from the age of 18 and above when they have eligible symptoms, but this works on a threshold of 10. Any patients presenting with symptoms of suspected colorectal cancer and a negative screening FIT, even if very recent, must be clinically assessed and have another FIT if they are eligible. Do not be falsely reassured by a negative screen FIT result. FIT has been found to be superior to symptoms in predicting pathology in patients with suspected colorectal cancer symptoms, and this is now reflected in guidance noted on this slide. FIT will support patients to have the right referral, investigation and management at the right time and according to their clinical risk of colorectal cancer. The negative predictive value of FIT is almost 100% at a cut-off of 10, and this rises with the inclusion of IDA. People with FIT less than 10, without IDA or weight loss or abnormal abdominal rectal examination, have a risk of colorectal cancer less than the background population risk. A local service evaluation by the University College London has also found that FIT is an acceptable test for patients. In a more recent study, it was found that 90% of patients found it easy to complete, and over 2/3 of patients preferred it to colonoscopy. As there is now new evidence and guidance, our use of FIT and our suspected lower GI cancer referral practice is going to change. Importantly, this is supported by primary and secondary care leaders across Cheshire and Merseyside. Which patients are included? The new pathway applies to all patients aged 18 years and above with the following symptoms: unexplained abdominal pain and/or unexplained weight loss, change in bowel habit, unexplained IDA or previously uninvestigated IDA in men and non-menstruating women, noting that for menstruating women with IDA should only be referred with a positive FIT. Where IDA is found in patients under 60, ensure it is unexplained by considering or excluding other causes such as celiac disease, hematuria, blood donation, menorrhagia and pregnancy. We also include anemia without iron deficiency, which is unexplained, especially in those 60 and above. Unexplained rectal bleeding and with abdominal pain, change in bowel habit or weight loss, anal or rectal mass, anal ulceration and abdominal mass. There are stages of assessment required in primary care. So we start with a patient with signs and symptoms of suspected lower GI cancer. We undertake a clinical assessment including history and examination, and depending on the findings, then go on to consider IDA status and other bloods. We then also need to consider if FIT is necessary. When is FIT required? This falls into 3 groups. The only patients who will never require a FIT would be those with an anal or rectal mass and/or anal ulceration. They will require an immediate referral. The second group are patients with unexplained IDA and/or abdominal mass, and they will need a FIT requested at the point of referral. For all other patients, they will need a FIT result in order to refer, noting that referrals can still be made where there is serious ongoing clinical concern and/or the FIT has not been returned, and that individual clinical judgment should still be used. Note also that rectal bleeding now requires a FIT. This may feel counterintuitive, but over half of those with this symptom will have a negative fit. Important to note that taking the patient history into account is critical as part of the patient assessment, including their bloods and IDA. Abdominal and digital rectal examinations are essential prior to referral, unless there are exceptional circumstances. Remember to share the findings in your referral, and if they cannot be performed, please state why in your referral. The reason for this is to exclude the presence of clinical findings which would trigger an immediate referral or consideration of another pathway, such as gynecology for suspected ovarian cancer. Clinical findings will also influence whether a fit is required. Importantly, persistent or recurrent anorectal bleeding with a negative fit will still require a referral because it may change the investigation used by secondary care. For patients where a fit is required, supporting completion of the test along with safety netting will be essential. Counsel the patient around fit. Explain why they are being asked to do the test and how important it is that they complete it. Explain that the fit pack will have an easy to understand patient instruction leaflet for them to go through. The patient's stool pot and any forms will need to have the right details on, so it is worthwhile highlighting this to the patient. Return the fit to the GP practice as soon as they can, and also tell the practice if they are struggling in any way to complete the test. We are also working with organisations to make fit packs more accessible in practice, and we are piloting ways to do this during 2023. GP practice safety netting and things to consider include the following: tracking the fit requests as you would for PSA, CA125, etc. Patient reminders such as using text messaging with a link to the patient instruction leaflet, which will be available on local websites. IT-based safety netting, such as the Cheshire Merseyside safety netting template, which is available via the Cancer Academy website. Ensuring raised fit results are actioned as soon as possible and the patient referred onto secondary care. Identifying non-returners to encourage fit completion and availability of result. And ensuring that those with a negative fit are clinically reviewed in case a referral is still required. Fit results must be interpreted in the context of other results, examination findings and clinical concern, which is why it is so important to complete every element of the patient's assessment. Never interpret a negative fit result in isolation, because some patients with a negative fit still need to be referred. You may think of the 3 N's, so a negative fit, no iron deficiency anemia, and no mass and no anal ulceration. These patients only need to be referred on a suspected lower GI referral pathway if there is serious ongoing clinical concern. If patients have a negative fit with no unexplained IDA and/or persistent anorectal bleeding and/or have a normal clinical examination, consider all of the following: an alternative urgent suspected cancer pathway. If they are fit negative with normal clinical findings, consider a non-specific symptom cancer service. Consider clinical reassessment. You may want to offer a second fit test if there is ongoing clinical concern. You may want to consider looking at advice and guidance at your local trust. The indications to refer onwards to secondary care on the new urgent suspected lower GI cancer pathway include the following. The first 2, anal, rectal mass and anal ulceration, do not require a fit result. Unexplained IDA and abdominal mass require a fit requested at the point of referral. Raised fit plus or minus other features should be referred. A negative fit and unexplained IDA, or with persistent recurrent rectal bleeding, or with serious ongoing concern, should also be referred. It's important to note that we have created a new referral form for urgent suspected lower GI cancers. It has been created collaboratively with primary and secondary care cancer leads to ensure that if the referrer completes it fully, patient triage and prioritisation will be optimised. So in summary, nationally, FIT is now recognised as being superior to NG12 in detecting patients with suspected colorectal cancers. The new Cheshire Merseyside pathway for suspected colorectal cancers will require a FIT result to accompany referrals in many cases. The new pathway includes all patients 18 and above, which is more inclusive compared with NG12. We will no longer refer to NG12 and DG30 guidelines. I hope this short video has provided you with an overview of the important changes taking place in Cheshire Merseyside to how we will now identify and assess patients with suspected lower GI cancers in primary care and why this is happening. These changes have the potential to change the way we diagnose lower GI cancer and improve our patients' experience, enabling them to avoid unnecessary invasive investigations and, if needed, receive the right diagnostic test in a timely manner.